It is our tradition for our former UBERT mentors to introduce our UBERT alumni, who are the folks we asked to come back and give a talk. So, Dr. Bill Dantzler.
You better give me that. It's a real pleasure to be back here again. Not that I've been very far away. I am retired, but I am not that very far away. But it's a particular pleasure to introduce Oscar Serrano to this audience and to welcome him back to the University of Arizona for about the first time in 20 years. Now, Oscar, as you probably see and have you seen in the bio sketch, is now an abdominal transplant and hepatobiliary surgeon at Hartford Hospital in Connecticut and an assistant professor of surgery at the University of Connecticut School of Medicine. But that's not how I remember him. I remember him as a UBERT student in my laboratory. Now, Oscar was a biochemistry and MCB joint major, and he graduated with highest honors in both of those programs. But I was fortunate enough that he chose to do his UBERT program and his honors studies in my laboratory, and his Bravo program with two of my collaborators in the University of Würzburg in Würzburg, Germany. And so I was very lucky. Of course, he did follow in the footsteps of another UBERT Bravo student, also from Globe, Arizona, as Oscar was, and that was Cristina Martinez, and she's been back here before. But I remember Oscar very well. He was an extremely hardworking and enthusiastic student, and it showed. He managed to be a co-author on two major studies from our lab, and one more from the group in Würzburg. So that was a lot. And I can't help telling a few stories about Oscar. Well, I won't tell many. I'll be very good. I'll be very good. But Oscar, as I said, was a very hard worker. And he loved to work on weekends, which appealed to me because I like to work on weekends too. And and this was an earlier day. It was a day before you were streaming music on your cell phones and listening to it with earbuds. In fact, people used to listen on the radio, if you believe. And we had a small radio in the lab, which was next to my office, but it was usually turned way down. And I would come in on Saturday and I'd be there, and then suddenly this radio would come blasting out with hip-hop music. I'm not sure what I won't go into whatever, but anyway, and Oscar was in. I must admit, although I can tune out most of those things, occasionally when Oscar got out of the lab, I was being a bit overwhelmed, and I would walk into the lab and turn the radio down. He obviously knew that was happening, and he'd come back in and turn it up again, but it was great fun having Oscar with us. And since then, he's gone on to do many things. He's completed residency in surgery he's been at both Johns Hopkins and Albert Einstein, and with a major 2-year fellowship in transplant surgery at the University of Minnesota. And in addition, he's spent at least 3 full-time years at the NIH doing research, and he's done research in addition to that, which he can talk about. But he can tell you about all those things and what his plans are for the future. I'm just delighted to have him back and to see how well he is doing. It's great, Oscar. We really welcome you back.
Wow. So I can't believe that I'm back, as Dr. Dantzler said, for the last 20 years I haven't been back here. And I'm really flattered. I thank Dr. Dantzler for that introduction. I thank Jennifer, Carol, for the opportunity to come back, and most importantly, to show the students what is possible if you put your mind to it, you throw in some hard work, and you maybe get a little lucky. So what I want to talk to you today is about inclusion and the importance of inclusion in research, in biology research, in medicine. And inclusion is basically a way for us to get everyone to the table. Inclusion is an opportunity to hear people from different backgrounds. And this isn't going to be a talk about ethnic minorities. This is going to be a talk about an all-inclusive healthcare for 2020 and beyond, right? So when we think about minorities, most of us think of racial minorities, African Americans, Hispanics, Native Americans. But if you think about it, and I'll give you some information, some data in a few slides down the road, minorities encompass anyone with a handicap, LGBT, elderly. So without further ado, I want to get started in speaking to you about disparities in healthcare and why your inclusion into this discussion is critical for the well-being of your community. I have no relevant financial disclosures. These are some of the things that I'll be talking about today. I want to start out with just a personal background, tell you a little bit about where I came from, define health disparities, and then give you some examples of them, and then talk about what I'm really interested in now, which is disparities in kidney and liver transplantation in Hispanics. And then I'm going to talk to you very little about the clinical research that I've gotten started. I've been at the University of Connecticut at Hartford Hospital for about 1.5 years, and I've been able to get started on some projects. I've had some students, just like you, come and work with me, and then I'll give you some parting words. So it all started for me in Ciudad Obregón, Sonora. So that's where I grew up. This is where it lies. It's right on the Sea of Cortez. It's a city of about 430,000 people. An equivalent city would be Minneapolis, Minnesota. So in 1989, my father is a mining engineer, so we moved to a small town of about 7,000 people in central Arizona. It's called Globe, Arizona. When I was Googling it for a picture so that I could put on this slide, I found this picture to be very nice. It had the blue sky, the mountains, and everything, and I didn't realize that the picture actually encompasses the entire town. So this is the high school that has been sitting there for over 100 years, from which I graduated. There's a public library here. There's an old railroad station here. This is the Catholic church where we used to go to. This is the Safeway, where we could go to and walk from the high school to get sodas in the middle of the day. This is the old post office, and this is City Hall, and this is Main Street. And that's it. That's the town. Everything else is little houses all throughout the mountains. There's a little elementary school here, and there's a middle school somewhere here that it wasn't caught on the picture. And then I came to the University of Arizona, and wow, was that a culture shock, right? 7,000 people in my entire town, and the University of Arizona at the time when I got here had 38,000 students. That doesn't count the other 20,000 people that work at the university and make a living off of it. So for me, it was a real big shock. And one of the other things that I want to stress upon you as a student, and we talked to a smaller group last night about this, when you find at the university, at a huge setting like this, a Mark Tischler, a Carol Bender, a Bill Dantzler, who has an affinity for you, who wants to genuinely help you, you need to latch onto that individual and never let them go. Dr. Dantzler will tell you he receives emails from me sporadically still, 20 years later, because he was one of the foundations for how I got to where I am today. So here's my timeline, just to quickly go through it, just to give you an idea of where I've been and the things I've seen. So in '96, I graduated from Globe High School. 120 students in the graduating class, no more than 7 went to higher education. Everyone else either went to work for the mines, or went to stay in the town, or maybe went to Phoenix and became something else. From '96 to 2000, I was at the University of Arizona, and during that time, I was exposed to the international component of UBER, which was the Bravo experience. I spent a semester in Würzburg, and when I came back, I had applied to all kinds of medical schools, some of the best medical schools in the country. I was fortunate to get into my first choice. I went to Stanford Medical School, which I'm very proud of. But at the time, in the spring of that year, I felt a sense of what I now know was burnout. I thought, this isn't a way for me to start medical school, so I'd had that taste of international travel, international experiences, international research. Some of the researchers I met in Germany were phenomenal, taught me really the scientific process. So I wanted to repeat that. So I went with Dr. Giancarlo Papeo, one of the faculty members of the Bravo program, who's had many students, and Carol and I, with her vision, we decided to submit a proposal, and it got accepted. So I spent a year in Florence, Italy. I came back refreshed in 2001, and I spent 4 of the greatest years of my life at Stanford. But that being said, I only spent 4 years at Stanford, but you see, it took me 5 years to graduate. Not because I was slow. I took a year off, and I went to the National Institutes of Health. At the time, one of the hottest places to do research on tumor immunology, which is what I was interested in at the time. So I spent that year between my third and fourth year of medical school at the National Institutes of Health. I then started my residency at Johns Hopkins. And again, I took some more time off. Notice a pattern here. I worked hard, but I also didn't have a set path. I didn't have to graduate medical school in 4 years. I didn't have to finish undergrad in 4 years. So I took some more time off. I got another degree. Then I spent more time at the National Institutes of Health because I found it so rewarding. I was so interested in the work that they were doing. I decided to switch residency programs, and I went to Albert Einstein, from which I finished in New York City. And then I ended up my training at the University of Minnesota in Minneapolis, where I did my transplant surgery fellowship. And now I'm at the University of Connecticut. So I want you to see, little boy, little town, not a lot of resources, but every resource that I had, I took advantage of it, and I jumped on it. And I got to Florence, I got to Germany, I got to Johns Hopkins, the world's #1 hospital. I got to the University of Minnesota in the Midwest. I've been telling my wife probably in the next 10 years, we got to move to the South so I can cover all regions of the country. So now for the meat of the talk. Aside from biology and genetics, I want to pose a question to you. What determines someone's health? Right? We all get good genes or bad genes. We all have an intrinsic biology that determines whether we live to 90 or whether we die at 45 of a massive heart attack. So this is a question that actually is very important to the federal government. The American Medical Association has put out the social determinants of health. They basically are pillars on which your health, your outcome, how long you live, how well you live, is dependent, on which they are dependent. So there's 6 of them. Economic stability, whether you're employed, how much money you make, how much is in the bank, are you able to sustain a medical bill of $500 on a month-to-month basis, right? We've all read the CNN headline. Most people in the United States can't afford $500 to go to the emergency department. Your neighborhood and physical environment, where do you live? Do you live in the projects or do you live in a nice house? And we'll get into what a nice house is later. Do you have access to transportation? Do you feel safe at home? Do you have parks that your children can go and play in? Education. Are you able to read? We may find that as an odd question here in a university setting, but I have patients that come to see me who don't know how to read, and when I consent them for surgery, they sign with an X. What kind of language do you speak? Do you speak the language that most people around you speak? Do you have access, or do your children have access to early childhood education, which is known to have a significant impact on your entire life? Do you have access to training or higher education? Food. Do you ever go hungry? Or if you have food, do you have good food? Do you have access to good, healthy food? Community and social context. This is very important. One of the things that we're going to talk about today. Social integration. Are you integrated into your community? Or are you linguistically or culturally isolated? Do you have support systems? Are you engaged? Are you discriminated against? And the healthcare system. In America, we are all supposed to have equal health coverage, but we don't, right? Do we have enough providers to go to your community and take care of you the way that you would if you were in Tucson, Arizona at Banner Health? Do you have providers that can communicate with you adequately? So what's a healthcare disparity? The Institute of Medicine a few years ago got together and they basically defined that a health disparity is basically a difference in the quality of healthcare that is received that is not due to access-related factors, clinical needs, or preferences or appropriateness of the caretaker. This is important because in 2008, there are about 300 million people in the United States, more than a third of which are considered ethnic minorities. More than 50% of them are women. About 12% are considered disabled, even though they don't live in a rehab or other residential care facility. Almost a quarter of people live in rural settings, and we'll get into what rural means. And about 4% of the population, of our young population, considers themselves LGBT. As a result, in 2000, the National Institutes of Health opened up a new national institute. Typically, National Institutes of Health, we think of traditional medical National Institutes of Health, right? National Cancer Institute, NIDDK, the National Institute of Digestive Diseases and Kidney Diseases, the National Institute of Mental Health, Well, this one was the National Institute of Minority Health and Health Disparities. That's how important it is for the federal government to bring up to par these disparities so that everyone goes together equally. So, I'll give you examples of some health disparities. These are the most commonly known. The risk of preterm labor among African American women in the United States, right? So, African American women experience 11% incidence of preterm labor. Compare that to non-African American women, which is 7%. These are huge numbers when we're looking at millions of people. And we see that the care they receive is not the same everywhere, right? So these are risk ratios. The difference between the dark blue and the light blue is the difference between white people and African American women. And we see that depending on where you live basically determines how big that risk is. In some areas like Minnesota and Oregon, the risk is negligible. In other places like Louisiana or Wisconsin, there are huge differences. Hepatitis C testing for veterans. So we all think of the Veterans Administration hospitals as being uniform. They're all throughout the country and they're supposed to provide the exact same care. But we see here that not all veterans are tested for hepatitis C equally. We see that even within the same state, there's different percentages of people that get tested for hepatitis C when these are government-mandated norms. If we look at incidence of cancer among Native Americans, here I show the incidence of cancer among Native American populations between 2010 and 2015. They compare white, which in this slide are light blue, and dark blue is Native Americans. And we see here that there's substantial differences in kidney cancer and liver cancer for men. Here, less cancers were diagnosed, or if they were diagnosed, treated appropriately for colorectal cancer among Native American women than for white women. So these differences are what we're trying to get at here. What about the lifetime prevalence of committing suicide or attempts at committing suicide between heterosexual individuals and what we consider sexual minorities? Depending on who you ask, it could be 5 times as much. What about rural versus urban America, right? The darker the blue on this map, the more densely populated the community is. So if you look at the center of the country, it's filled with yellow, which means that these constitute as very, very sparsely populated areas or very urban settings. We find here, what I'm showing here, is if you come in with a stroke, with an embolic stroke, basically an embolus gets shot up into your brain, the treatment for that is to give you TPA, and we see there's huge differences between the rural and urban setting. And those differences are only getting worse as time goes on. That curve is supposed to be the other way around. So now I'm going to talk about what I'm interested in. We're going to talk about end-stage renal disease and kidney transplantation in Hispanics. Why is this important, or why do I think it's important, other than the fact that I'm Hispanic? Well, Hispanics account for about 20% of the US population currently. In about 50 years, that's going to double to 111 million. Currently, there's about 58 million. Okay? Hispanics are disproportionately affected by hypertension, obesity, and diabetes. If we look at hypertension, controlled hypertension, with the dark bar being non-Hispanic whites and the Hispanics being light green, we see that there's greater proportion among men and women of uncontrolled diabetes. Look at obesity rates, the same. Caucasians, dark blue, Hispanics, light green. This is really sad. You look at children, right? Hispanic boys are twice as much likely to be obese than whites. Why is that? If you look at the causes for kidney failure and why someone needs a kidney transplant, we see that Hispanics almost double as much as Caucasian whites. Their primary cause for disease is diabetes. We know that diabetes in Hispanics is a bad combination. It'll lead to not only kidney disease, heart disease, but eventually death. So the prevalence of end-stage renal disease per million here over the years continues to grow. More people are going on dialysis. Unfortunately, Hispanics, even though they're a minority of the population, their numbers are almost twice as much as Caucasian whites. But who gets transplanted? So we see in the United States, we do about 17,000 kidney transplants per year. Majority of them are Caucasian, as you would expect. Hispanics are right here. If we look at 2016, the number of people that are on the wait list. On the wait list, 36% of those people are white. 46% get a transplant. If you look at Hispanics, 19% are on the wait list, but only 15% of them get transplanted. So why do these disparities exist? Well, they looked at different things. You can say, well, language is probably the reason, right? A lot of Hispanics don't speak English. They looked at studies, and they determined in a study that was published recently, 85,000 people who were on dialysis, they found that if an individual in your household more than 14 years old spoke English, you were going to be okay. But if you had anyone in your family who could speak English was below 14, you were going to have less of a chance of being activated on the kidney transplant wait list. Activated is the only way you get transplanted. You can be inactivated or activated. Inactivated means you're not ready for a transplant. Activated means you're ready to go and eligible to receive a kidney from a donor. However, a very interesting study was done in Denver. Denver is a huge population center for Hispanics, and they didn't find this difference. Why do we think that is? Probably because Denver has more Hispanic doctors. So the language that a patient speaks impacts their chances of being transplanted and put on the wait list. If we look at income and socioeconomic status, in this study they looked at 700,000 plus individuals who were on dialysis. And they basically took Caucasian patients and Hispanic patients and African Americans. And they basically divided them up into quintiles of salary, right? So, and they found that despite that, the lowest quintile, so the people that made the least, and the highest quintile, the people that made the most, you could say, I'm in this quintile, right? There shouldn't be a disparity. There still was. There was no difference. So regardless of your household income, socioeconomic status, Hispanics are still being referred less for transplant. So why does this occur? In this study, they did a survey. They asked patients, why did you not get referred for transplantation? Not sure how to proceed was one of the top reasons. I don't understand the benefits of a kidney transplant. I don't understand the transplant process. And the number one reason, my doctor didn't refer me. This suggests some implicit bias. And these biases can be changed, at least from the patient side. In this study, this was actually a study out of Claremont University in California. They collaborated with the Arizona Donor Registry. So when somebody is asked about organ donation and whether they would approve organ donation, they did a mass campaign to try to talk to these individuals and find out why they're not being eligible for donation or why they don't believe in transplantation. And this, with their study, they were able to change people's perception. My family has discussed organ donation with me. Because of this, now families were talking about it. This was statistically significant change as a result of this mass campaign. My religious beliefs don't allow me to be an organ donor. Again, a reduction in that number, showing you that with education, people can change their perceptions. My family would not want me to be an organ donor. What about liver? If we look at the top causes for receiving a liver transplant in the United States today, we see that among men, alcoholic liver disease is the number one reason. Among females, it's non-alcoholic steatohepatitis, basically obesity related. We also saw that hepatitis C, which is in the gold, has gone down significantly as a result of direct-acting antiretrovirals against hepatitis C, which is essentially has cured. This is good, but for certain populations. For other populations, it isn't so good. Why? Hispanics suffer from the highest proportion of alcohol-related death, right here. Hispanics also suffer from non-alcoholic fatty liver disease in a disproportionate number. Here, they examined patients who were being evaluated for a liver transplant, and they found that Hispanics had a much higher incidence of NAFLD, non-alcoholic fatty liver disease. And it wasn't all diet-related. It wasn't all social. Hispanics had this mutation, the PNPLA3, and they found that if you were homozygous and Hispanic, that effect was pronounced. So if somebody does get a liver transplant, how do they go about getting it, right? So in this study, they looked at individuals who are either African American, Hispanic, or Asian. And when you compare them to an equally ill patient, in other words, using the MELD score. For those of you that don't know, MELD is a modified end-stage liver disease score. It's supposed to be, it doesn't take into account ethnicity, doesn't take into account any biological factors other than 3 parameters. And from those numbers, it determines how sick you are, how sick your liver disease is. So the higher your MELD, the more likely you are to get transplanted. And we see here some sobering statistics again. Hispanics, when you compare them with Caucasian cohort, for every MELD, when you account for MELD, how sick they were, they still got transplanted less. Similar numbers to before. Non-Caucasian whites, 2/3 of them are comprised of wait lists. 2/3 of them get transplanted. On the other hand, Hispanics, they account for 18% of the wait list, but only 15% of transplants. And if you look at the regions across the country, the map that I show here is how we allocate organs. The United States is divided into 11 regions as set forth by the United Network of Organ Sharing. It basically allows for geographic locations to make determinations as to how those organs are allocated. You guys are in Region 5. I'm in Region 1 up here in New England. And you see here that liver allocation, when you compare Hispanics versus whites, not the same. For Region 1, which is where I'm at, a heavily Hispanic populated area, Hispanics are less likely to be transplanted than non-Caucasian or Caucasians. For other regions like 5, a drop as well, even more of a pronounced effect. Region 4, Texas, an area with a lot of Hispanics, also has a disproportionate number of Hispanics that are being transplanted less. So these are huge problems, right? These are huge areas that have a lot of Hispanics in them, and Hispanics still don't have access to transplant. So what happens if you actually transplant Hispanic populations? Well, I find this very interesting. It's actually been coined the Hispanic paradox. What I'm showing here is survival. This is 100% survival. This is our Kaplan-Meier curves. 100% survival as time goes on. The probability of your survival on the wait list. So if you get put on a wait list, you're sick enough to receive a liver transplant or to need a liver transplant, what are the chances that you're going to make it out to 180 days to 270 days? We see Hispanics have a higher survival rate, equivalent to whites, but higher definitely than other minority groups. If you receive a liver transplant, or the probability of you receiving a transplant is much lower though. Hispanics rank much lower. What if you actually get transplanted? What if you're one of the lucky Hispanics who gets transplanted? What we find is that their survival is exactly the same as that of their Caucasian cohort. Much greater than African American survival. So if given the chance, Hispanics have similar, if not elevated rates of survival after they receive a liver transplant. So that's all the background. This is all information that I'm giving you to make an impression upon you about how important this is. I'm going to show you a little bit of research about what I've been doing at Hartford since I got there for a year and a half. So we wanted to evaluate this Hispanic paradox. We wanted to see, are Hispanics able to get access to kidney transplantation? In this particular topic, we were looking at kidney transplants. And if they get a kidney transplant, how is their survival afterwards? How well do they do? So we looked at the Scientific Registry for Transplant Recipients. This is a big registry. In the United States, everyone who is transplanted is tracked on this registry. Every single person. It's one of the most comprehensive registries in the entire country, actually in the entire world. And we looked at 1 and 5 year survival for patients and for their organs. So how long, not only does the patient survival important in transplant, but also when you put in a kidney into someone, does that kidney last a long time? Does that kidney last as long as the patient? Or does it cease to function at about a year? So I won't bore you with all the details. Basically, we looked at 250,000 transplants, and we basically divided it into groups: adults, children, non-Hispanic whites, non-Hispanic blacks, and Hispanics. And we looked at the various demographic characteristics This is just meant to show you how granular this database is. And this is what we find. At 1 year, we see that there are significant differences in adult outcomes for patient survival. For Hispanics, this is the red here. Whites and African Americans are green and blue. We see that their graphs also seem to last longer. Definitely a lot longer than for African Americans. For pediatrics at 1 year, the effect wasn't as pronounced. But if you look at their graph survival, again, you're seeing significant differences. What happens long term? 5 years. Again, all you need to see from these graphs is the red, right? There's significant differences in Hispanic outcomes that seem to suggest that if transplanted, their kidneys are going to last longer and the patients are going to last longer. That's a patient that we're going to get to the workforce. That's a patient that's going to utilize the graft effectively. So I'm going to leave you with some parting words. So I hope I've shown you today that disparities exist in healthcare, and they are a top priority for the US government. Your involvement in basic translational and clinic research is critical because no one is going to be a better ambassador for your community than you. If you don't advocate for your community, no one else will, or no one else may. Someone may, but ultimately, it's you who's going to be the best ambassador. And then rely on your mentors. Have faith in them. Have faith that they have your best interest in mind. I talked about it last night again with a group of students. When you find that individual, latch onto them and don't let go of them because they truly want the best for you. I know it sounds cliche, but never give up. The road that I've shown you hasn't been without obstacles. It's been a long, hard, arduous road, but enjoy the ride. Enjoy and savor the ride. And your questions and your research is important. So this is my family. This is that's right. So I just want to close by saying that this has been great. I couldn't be up here without I have a lot of people to thank, and I'm not going to go through every one of them because I'm going to get choked up. So if you have any questions, I'm here. Hopefully I can answer them. No, so that's actually a fantastic question. I actually have a research background in that. One of my other trainees just recently presented data from our center looking at taking these, what they call extended criteria donors. So extended criteria donors. So everyone wants to have the perfect donor, right? Everyone wants to have the 25-year-old young person who didn't drink, didn't do anything, wasn't obese, who got into a motorcycle accident as their donor. Unfortunately, that doesn't happen. The average donor age in the United States is 54 years old. Most of them have cardiovascular disease. So the problem is that many organs come from older individuals. In the United States, we define older individuals as 60 years old. So if you actually calculate the score for many of these organs, they go beyond what anyone would transplant from more conservative programs. The program that I'm at is actually fairly aggressive. We tend to take organs from 70-year-olds all the time and put them into 70-year-olds because that organ is not going to last forever, but I tell many of my patients, neither are you. And so when you look at these disparities in the utilization and organ discard, they are very profound. They actually just recently did a study in 2017 coming out of France, and they looked at this same registry that I'm using. And they looked at the criteria that the French use for utilizing organs, the age criteria, the weight criteria, and they found that we had discarded over a 10-year period somewhere in the range of 26,000 more kidneys that they would have used. And it's a very hot topic in transplantation. The problem is, and here is the problem, transplantation is a very regulated field in the United States. And so if our outcomes don't meet a certain criteria for a certain period of time, so it's usually an 18-month period, if we don't have a 96% survival or better for our kidney grafts, then we will be marked as in trouble. And the public can see that, and therefore nobody, when you go into a transplant program, you don't want to go to a transplant program that's in trouble. So part of it is a regulatory aspect of it. Part of it is the apprehension from clinicians, the lack of experience. Whereas, as I said, Europe is the model. In some European systems, they have the opt-out system as opposed to opt-in system. That means opt-out means that rather than you going to the DMV, getting your license and saying, yes, I check off to be an organ donor in Europe, in Spain, or in some countries in Scandinavia, they don't ask you. You are assumed to be a donor unless you say, I don't want to be a donor. And so in these countries, they use 70, 80-year-old livers and kidneys. And of course, the outcomes are not going to be the same for everybody. But if you take them by age group, they actually tend to do better than we do. So earlier I showed some slides about preterm labor in women. In transplantation, if you're talking about, there are also disparities for women. Women, very much like an ethnic minority, there is something about the provider that will make them to be less referred for transplantation, just like the cardiovascular disease literature, right? So the symptoms of a heart attack in women are different than in men, and so they're not recognized as quickly. So very similar trends, which is why this area is very important. This area of medicine is very important, and so much money has been spent on disparities research. But you're absolutely right. Looking at pretty much every stage, every disease process you could, you're going to find disparities where women or any other minority, not necessarily ethnic minority, will have lesser outcome or lesser care as a result. Right, so a difference, a disparity is a difference, but a disparity is a difference that's modifiable, something that can be changed and should be changed. So the way to look at it is, if you have hypertriglyceridemia, right, a genetic disorder, and you die at 45, there is a difference between you dying at 45 versus someone who doesn't have that disease. That's a difference, that's a genetic difference. A disparity is a 45-year-old who dies of a massive heart attack who didn't have hypertriglyceridemia, who also happens to be either LGBT or African American or obese because they didn't have access to adequate nutritional care back when they were young. That's the difference between a disparity. Disparity you can fix, or you can try to fix. You can try to find factors that are modifiable. That's how I see it. So I think a more diverse healthcare workforce, is certainly a component. It's a multifactorial answer. If I had the one answer, I would probably be getting every single grant from the National Institute of Disparities. It's multifactorial. It relies on those 6 pillars that I showed at the very beginning, where environment, physicians, not only physicians, but other healthcare takers. And so it's not just about increasing diversity in medicine, which I also think is important, right? I would have never gone into this type of research had I not been allowed into medicine and seen the huge disparities there are in my people and why it's important for me to push it across. So this work that I've shown you, that I failed to mention that the work that I showed from Hartford was done by an undergraduate student at Boston University who came to work at Hartford through a program similar to UBERP. And the work that he and I are doing is being done at 6 other centers around the country. That's it. No one else is looking at this. And I just got started in this. You would imagine that somebody would have jumped all over this and started submitting grant proposal after grant proposal. The interesting thing is that all of the individuals that work with me aren't ethnic minorities themselves. They're not Hispanic. I had this kid from the University of Connecticut. He was from Boston University, but he was from Connecticut. Middle class, grew up in a well-to-do family. He's now going to medical school. And he became an expert over the summer in Hispanic disparities. And I said, when you go and talk to people and you explain your research, you need to explain why it's important. And it's not just Hispanics studying Hispanics. It's important for people to understand that it is a significant problem, a problem that should be at least, there should be attempts to fix it. Okay? So, thank you.